My name is Mandela Oguche. I think I've worked with Vicky for quite some time, close to about three or so years. So I work in Kenya. I work at Elvizity Health. So Elvizity Health is a local organization in Kenya that predominantly deals with HIV and testing services. But then they expanded to a lot of work in research, and then they also do a lot of work in community health. So that's where I've been for quite some time. So I have great experience working with community health units. In Kenya, we call them community health units. I just realized that here we call them community information information teams or something.
They're community innovation teams, but that's
Yeah.
what we call them in our project.
Yes, so I worked very closely with community units back in Kenya. So the difference with how we work with our teams is mostly to help them really recognize their potential in terms of providing services at the household level and ensuring linkage of these services back at the facility levels. So we don't provide infrastructure kind of level where they're given certain aspects of commodities and that, but we ensure that they realize the level of potential they have. We also build capacity of the CHPs, so community health volunteers that we work with. So we build their capacity, we try motivate them so that they are able to achieve certain aspect of community health services that they give. So we also empower the national level teams, the county level teams, and sub-county level teams so that they are able to supervise, mentor, and really coach the CHPs appropriately because this is what is really needed back there in Kenya. Supervision, mentorship, and coaching is a very key element of that. But our area of work in community health has also informed a lot of policymakers to just come up with documents that really instruct a proper utilization of CHPs in terms of community health service delivery. My background per se is I did medical social work. So I think what I learned in school and my experience in working with community health volunteers has really shaped my interest and passion towards working with people at the community level.
Amina, I see you there.
Mm.
And I think you should have the opportunity to say who you are too before we get going off with Vicky. If you could unmute and just say something, please.
Hello, I just tried to sneak in. I do apologise.
No such luck.
Undetected and under the radar. So my name is Amina Ismail. I'm a senior community mobiliser at the Liverpool School of Tropical Medicine. I work alongside Vicky on the health, on a number of projects, but of recent, the Health Equity Liverpool Project. So working with community innovation teams across Liverpool and basically supporting them to deliver innovations that are informed by local data and bespoke to the communities that they are situated within. And through a mechanism of conversation, dialogue, and co-production with communities. Prior to that, I worked on the Vaccine Equity Project with Vicky. And I have a background in education. And so I've transitioned into working in, community health and public health arena. So hello, everybody.
Hello. There you go.
I do apologise. I have an 11-year-old who might jump on the camera, which is why the camera is off.
I think as both Amina and Mandela will attest to, we've got a major learning event happening this week where we're bringing all the teams together, the Liverpool City Council, the ICB, the Integrated Care Board, various different funders and health stakeholders, community organisations. So it's going to be, we call it a festival of learning. It's going to be a lot of fun. But we want to make sure it's as good as possible, and that's the stress we're going through at the moment. But we're all under control somehow. So anyway, let me without further ado, just for those who, I think most of you do know me, but I'm co-director of Capacity Development International, which is a Liverpool-based consultancy company, and we basically provide technical assistance to predominantly our work has been in sub-Saharan Africa, actually, working with ministries of health and NGOs, supporting them in strengthening the capacity of their health systems, their community health systems, strengthening mid and senior level management. We also do some evaluations of programs, trying to do it very much mixed method approaches, and trying to sort of challenge people's thinking in terms of how they deliver services and how they strengthen capacity within the health system. More recently, I've become involved in UK work, mainly because of COVID. Getting fed up of doing everything online, and we had a chance to get our hands dirty in Liverpool, so I thought, well, why the hell not? So and the trouble is, the result of that is that we're now very busy in Liverpool as well, which actually is being very exciting work, and all kinds of exciting things are happening, but it just means we're sort of rather busy. I'm also a honorary staff member at the Liverpool School of Tropical Medicine. That's what brought me to Liverpool in the first place, as well as my love of salsa. And just as an aside, I used to make more money out of salsa dancing than I did on the salary as a research fellow at the Liverpool School of Tropical Medicine. So that just tells you that research fellows don't get paid very much money. Yeah, there's lots of different slides here. I want to give you some examples of what the community innovation teams do. Sort of show the model that we've been using, that got adapted from Kenya, and then I think end up with just some of our thoughts about sustainability and scale up, because as I said, one of the biggest challenges for us is everyone, but a lot of people are talking the talk. They talk a lot about, the importance of engaging with communities and giving communities a voice. But actually, when it comes into practice, I would say that doesn't happen so well. And so that's what we're, I suppose, grappling with at the moment is when you get these good examples, how do they go beyond projects and actually turn into something that is sustainable? So I hope you can see that. And let's get into slideshow. Can we see the screen okay? Yeah, great. Okay, so I'm going to be talking about sustaining a community-led model for improving health equity. And, we talk all the time about communities tackling avoidable and unfair differences in health. And that's what we mean when we talk about health equity. And certainly in Liverpool, Matt Ashton's, Director of Public Health, his recent report highlights that actually these inequities are increasing, and that we need to start doing things radically different if we're going to actually see improvements and reduce these inequalities across the city. I think likewise, the work that I've been doing in Kenya again highlights very similar issues. And so really, the reason that we've been working on this community-led model is because we feel that this is the only way you can really tackle health equity from the grassroots up. And the only way you can do that is this is a mantra that myself and Amina use a lot. Our communities are experts in their own health, and they know best what will work, what interventions will work within their own communities. And I think a really good example is when we were looking at COVID and some of the national messaging, and how really some communities just totally disengaged from health services and stopped listening or taking advice. And it was actually, I think, certainly what we saw in Liverpool was very divisive. And I think Liverpool now is having to pick up a lot of pieces in terms of recovering from COVID and regaining that trust. And we firmly believe that the only way to really do this is through a community-led model. So maybe I should talk a little bit about what we mean by that. So in our Health Equity Liverpool project, this has been we've been doing this since 2021. Originally, because we were asked by Matt Ashton to come in and help them tackle some of these issues around vaccine inequity, and really trying to engage with communities who didn't want to engage with them. And we were at that stage actually working with in Liverpool-Wide, where high ethnic minority population. We were working in the north of Liverpool, where white men, so working class men under 50, very hard to reach out to them. And we were also working with the Chinese community. So we're working with very different groups trying to tackle this issue of vaccine inequity. Once that phase of the work finished, we're currently been working on looking at childhood immunisation, particularly MMR uptake, which is incredibly relevant at this point in time. And then we've also been looking at cancer screening, again, which fell behind a lot during COVID. And we've been focused there on breast and cervical screening. And again, trying to engage with communities in pockets of Liverpool where uptake has been incredibly low. That is both for MMR, breast screening and cervical screening. But just to talk you a little bit through the model, it's quite a simple model. What it's all really about is trying to get what we call a community innovation team, and I'll explain what that is in a minute, to use local data and to look at what their local data is saying and to use that data. So we talk about local data for local use. We also get them to combine, and when we talk about that local data, we're talking about the EMIS data, the data on the GP. So the GP records and looking at what that data is telling them about whether it's immunisation, breast cancer screening, cervical screening or whatever. So they're looking at that data and really trying to drill down to where are those health inequities? Why is it that certain communities are not using these services? Why is uptake so low? We then combine that with behavioural insight work and bespoke messaging. And I think this is the important thing. So you're not just saying, well, what does our data, our sort of routine health information system data say? We then also, the teams go and actually speak to their target population and try and find out, why is it that you don't want to vaccinate your child? Why is it that you don't want to go for breast screening or cervical screening? So they obtain those insights, and they do those through working as a community innovation team, which is not just a primary healthcare team, it's multiple stakeholders and working with community organisations, volunteers, who are trusted within their own communities. So getting those insights becomes much easier. If I think back to when we were working during COVID, we were also working with a social marketing company, and they were sending people door to door to try and find out why people weren't getting vaccinated, and they could barely speak to anyone who was unvaccinated. Whereas when we worked with our community champions, they were incredibly successful at going out and talking to people who were unvaccinated, and they were able to get their stories and find out and gather those insights for why people were not willing to go. And the beauty with that survey, actually, it was an online one, and you can actually see the length of the conversations. And with the private sector organisation, when they were doing their door-to-door, you could see that the conversations last 5 minutes. Whereas when we looked at the conversations, so how long the surveys lasted, which were being conducted by the community champions, those conversations were going on for 15 or 20 minutes. So you could see that there was a huge difference in the level of engagement that was happening. And we believe that was down to trust and sending people from that community into the community to gather those insights. And then what we do, we get those community innovation teams to look at their local data from the primary healthcare system, combine it with that behavioural insight data, and then they can come up with bespoke messaging to their communities. So they know how to talk to communities in a way that will be heard. And so that is where we talk about those people-centred local solutions. And we take the teams through a simple cycle of quality improvement where they're looking at their data, they're coming up with potential innovations. We provide funding. It's an innovation fund where the teams look at their data, they do a root cause analysis, they come up with potential solutions, they turn it into a plan, and then the project gives them the funding so that they can test and implement that and measure the impact. We then, at the end of that, we have these learning events where we bring all the different teams together, and they present that work of what they did, what worked, what didn't, and so they can learn from one another. And also at these learning events, we have decision makers and sort of local policy makers there, so we can advocate for this approach and also hold them to account. We have great panel discussions where we sit them all up there and ask them difficult questions. And then the idea after that is then we look at what can be replicated with the ultimate aim of increasing health equity. So that's in a nutshell what the model is. And so here's an example of one of our community innovation teams from phase one, who were working in the sort of Liverpool-Wide area, which is, as you can see, is a very culturally diverse team because that area is very culturally diverse. And this really is, there's a great film here actually all about our model. I can share all the links later, or actually I'll just share the PowerPoint, then you've got the links. And this basically summarizes, it's about looking at that health data combined with community insights, phased training. I think that's been one of the other very important things with the model is we don't just do a one-off training. We have short periods of training interspersed with implementation and coaching. So Amina is one of those coaches, and actually so is Mandela in the different contexts where they're sitting with the teams, kind of encouraging them, providing them with that sort of, I suppose, impetus and support to keep going, to keep trying different things. And they test different local interventions. And often this is with this very bespoke messaging. It could be video stories, it could be photo exhibitions, it could be poems, a lot of community outreach events. These are the kinds of things that they're doing, but they're going into their communities. And so bringing that health messaging, that preventive and promotive messaging into the communities, and trying to provide that link to primary health care. So the whole idea is that it's about trying to avoid working on health equity in silos or in parallel by making sure you've got the right people in that community innovation team. Because we know that if you have that multidisciplinary team, people coming in with different lenses, then you're going to have a far broader view of what the problem is and how to tackle it. So it is about combining different structures and stakeholders so they can really make a bigger difference over a longer time. So yeah, just a little bit about our innovation team. As I think I've already said this, that most of the members are very trusted within their own communities, and these are partnerships. These are working partnerships. So you've got the primary care network, you've got primary healthcare staff within that. There might be a primary care manager, you've got data people in there, you've got social prescribers, you've got nurses, we've got community leaders, community champions and their organisations. We have volunteers in these teams and other health stakeholders who are working in that area. And more recently, we've actually also introduced creatives as well. So artists, poets, musicians to work alongside the teams as well, because we feel, again, when you're trying to build that trust and you're trying to look at what we call wicked problems, sometimes you need to have that broader health lens. So those are what community innovation teams are. They're normally between sort of 10 to 15 people in the team, and they meet once every 2 weeks for 1.5 hours. And they're there, once they've developed their plan, they're there monitoring its implementation and sort of looking the whole time of what they could be doing better. So again, I think I've said this I've already sort of, I suppose, summarised this about what they're doing. And their overall aim is to increase health equity amongst those target populations, those vulnerable populations or underserved populations. We like to talk a lot about hardly reached as opposed to hard to reach, because I think when you use the term hard to reach, it's almost putting the blame on those communities. The problem is, I think often as primary care providers or health providers, we fail to understand the communities we are serving, and we then blame them. They're hard to reach. No, they're not hard to reach. They are hardly reached. And we need to find a different way of going in and talking with them and actually building that trust, building those connections. So that's what the KIT does, the Community Innovation Team. I just mentioned about learning events because that's kind of where a lot of the kind of thinking and the sharing and learning culminates. And these are very sort of interactive events, very inclusive because you've got community volunteers to sort of, to directors of public health there. So all kinds of cadres, different levels of expertise. And so these are very interactive and dynamic, these events, where we're really trying to share learning, share innovation, advocate for change. They're very visual. We have music, we have movement. We barely sit down. We don't have death by PowerPoint. That's one of the rules. Really to sort of, again, try and get people to think differently. And this is like the visual minutes from our last learning event, which was about a year and a half ago when we were tackling COVID-19 and vaccine inequity there. So I'm hoping we're going to have an even better one in a couple of days' time. But they are sort of a central part of the approach as well. And as I said, we use a range of very different methods, poster presentations where people are walking around, teams are presenting their work back. We have panel discussions. We've also in Kenya, we use world cafes, and sort of, again, various different methods to try and get people to think differently. So where did the model come from? I did say, a lot of this work came from the work we've been doing in Kenya. And the interesting thing with Kenya is they have a very strong community health strategy, and sort of the community level is recognised as the foundation of Kenya's national health system. And, in many ways, when you're a sort of a resource poor country, community health makes a lot of sense, because if you can get it right at the community level, then it means it's a far better investment in your health expenditure if you can keep your communities healthy and safe. And I think what we saw in Kenya and what the Kenyans were saying to us is the problem is the interface. It's this interface between the community level and the primary healthcare level. And I think this is exactly what we're seeing also in the UK. There's this disconnect between the community and primary care, and how can we strengthen that interface? And really that is why we came up with this kind of community-led model and so the community innovation team model, where you could straddle the two. I always remember when we first started our training in Kenya and we were speaking to community health volunteers. And after we've been doing the work with them for about a year, one of the things they said that was most rewarding was that when they accompanied the pregnant woman to a primary healthcare centre, they were now being recognised by the primary healthcare team as a part of their team, whereas before no one knew who they were. So although they were working hard in their communities, trying to give the right messages to pregnant women, they would then take them to the primary healthcare facility and virtually be ignored. And again, and it didn't make them feel good about their work, and wasn't good for their own status as being recognised as someone who was working in this area. So I think, that's been a really important part of the work, actually. I think it's that interface and getting the trust between the community and the primary healthcare. And so what we've seen, as I said, was the need to strengthen really this interface between the two. And certainly what we've seen in Kenya is that community health workers, who are often volunteers, who are often unpaid, is with the push for universal health coverage with the Sustainable Development Goals, they're being seen as like the final common pathway for many vertical programs. And the community health volunteers end up getting used by different programs. Oh, the community health volunteer can do this, the community health volunteer can do that. But often they're unpaid or paid a very, very low stipend and then expected to do all the work. And one of the things what we saw was that the quality improvement had been missing in community health programs. In Kenya, they've been doing it all the way down to the facility, then it stopped there. And so really, again, this model of trying to build these community innovation teams was about giving them the skills, the structure, the support and the tools to be able to do this. And that's why we tested this model in Kenya as a community-based approach. And this time we were looking at improving equity and quality of antenatal care. And so we then took that to Liverpool. And so when we look at Liverpool, and I'm giving the example of Homa Bay here, which is where Mandela is working, there are some similar health equity challenges in reaching underserved communities. I think what we see in Homer Bay, though, is there's similarities, but also it's a very different picture. And Homer Bay has over 2,500 community health promoters who are embedded in the health system. Most of their focus is on mother and child health. So it's that early identification of pregnant women. It's getting them into the primary care system as soon as possible to try and avoid those complications in pregnancy. And then it's ensuring that those first 5 years of a child's life are supported as much as possible. But what we've seen there is challenges in the community health promoters receiving their stipends. We see NGOs and projects using the platform. So we see them as kind of taking advantage of the CHVs. I think sometimes the youth voice isn't fully incorporated. And what Homer Bay is struggling with now is there's a new focus on how to establish primary care networks. And so whilst Mandela is here in Liverpool, he's visiting primary healthcare facilities and trying to also understand how so the primary care network structure here compared to how things have been done in Kenya. And then when we look at Liverpool, what we've seen there, we've seen the focus on community champions. These were employed by Liverpool City Council during COVID in an attempt to try and reach out to the more Black and minority ethnic communities. We've also seen recently a push towards a neighbourhood model, and also the work with the community innovation teams. But again, here we've seen a lot of challenges in sustaining the workforce. Community champions in Liverpool, there's only 11 of them, unlike the 2,500 community health promoters in Homer Bay. And so in Liverpool, the model has been far more trying to also work with community organisations and volunteers. So in Liverpool, they're very limited in terms of the number and capacity. And what we've also seen in Liverpool is that primary care networks have very, very different experiences of working with communities. Some are very good at it. They have network engagement leads. They're really kind of already done a lot of work in trying to build that trust with communities, whereas others, they are far more just about health service delivery and have very little connection with the communities that they're serving. So a very different picture there. And I think what we've seen with both is that they require very much localised strategies to address that interface between community and primary healthcare. And in fact, we've just been awarded a grant by the Tropical Health and Education Trust, where we are partnering. We're doing an exchange program between Homer Bay and Liverpool, where we have senior decision makers and policy makers. We have people like Amina, senior community mobiliser. We have youth advocates, and we're sending a team from Liverpool going to Homer Bay to see how they're doing it. And then a similarly matched team from Homer Bay are coming to Liverpool, and Mandela is the first of that team to be in Liverpool to sort of learn from what has been done here. So although different contexts, often similar, I think there's a lot to be learned in both directions, and that's what we're hoping with this health exchange. So we've been trying to expand our work across the Liverpool City region to tackle health equity. Initially, we were just working with one primary care network. We funded 4 primary care networks, but then several others. In fact, we invited all the primary care networks to the training, and actually 4 of the other, there's 9 primary care networks in Liverpool, and 4 additional ones came to that training, and they've also been trying to tackle health equity, but without the technical assistance and funding that we've given the other 4 teams. So, but I think we're quite excited to hear what they have to say at the learning event and sort of the progress they've been making. We've also been working with arts organisations and community groups towards a more creative health approach by harnessing, creatives with a focus on storytelling to tackle health inequity. And so our help project, which initially had less of a creative element, has now, I think we were very inspired by Recite and have been working a lot closer now with creatives to sort of help the community innovation teams come up with more sort of innovative solutions, or more, as we like to talk about, creative health solutions. So what can the model achieve? I think what we've seen is that there's a lot of community organisations and groups and the community champions. We're seeing a much larger number, much more community engagement than was happening previously. I think the behavioural insight work has been really important in terms of then coming up with this bespoke messaging and coming up with bespoke assets, whether that's videos, photos, and I'll give you some examples in a minute of some of these assets, really trying to talk to the communities which are not engaging with health services, because all of this work, as I said, is focused on health equity. I think what we have shown is that we've been working in COVID, now we're working on looking at MMR uptake, cancer screening uptake, and the model has been flexible enough to flex to these different conditions. I think what we have seen is where it is working, we are seeing that, that it's building that trust and that increased trust. I think one of the primary care networks we've been working with, they've been working really closely with this is in Everton and Anfield. They've been working with a community organisation there, and that partnership is going so strongly now that they're now together setting up a charitable incorporated organisation so that they can together now bid for more money and come up with their own strategy of how they can work together to tackle some of these massive inequities they're seeing in that part of the city. Definitely, I think this model is very much about trying to increase the team's capacity to understand and use data. I know in Kenya, where you see really weak information systems, a lot of it is paper systems. And you think, oh, well, in the UK, it's far better, it's far more sophisticated. But I would say that we've seen exactly the same kind of capacity problems in the UK as we have in Kenya. People collect the data is of very variable quality, and people are not really using that data. They're not really drilling down or trying to understand it in a way that they can then bring about those changes in health equity. And I think what else we've done, we've developed some bespoke dashboards with the community innovation team so that they can track their interventions and they can look at the overall outcomes that they were trying to improve. So, for instance, if it was breast screening, have they managed to reduce the number of DNAs that did not attend? But also tracking the interventions. What were they doing? Community outreach events. Conversations with people, and so and social media, use of social media. So they're tracking those as well to really see, well, are these interventions making a difference or not? So what I'd like to do now is just give you some recent examples from Liverpool, just to make it a bit more practical and real. So this one is from the Central Liverpool Primary Care Network and North Liverpool. And when they did their initial work and collecting those insights, and they did say, trying to talk to parents who hadn't vaccinated, who'd chosen not to vaccinate their children, was incredibly difficult. People didn't want to talk about it. They said it was far harder talking to people about MMR than it was about COVID, actually, which was quite interesting. And what came out really strongly there was a real mistrust in MMR. And a lot of misconceptions around immunity and side effects. That came out really strongly. But what also came out really strongly was this heavy burden of parental responsibility. Parents wanting to do the right thing for their children, but really conflicted as to what information to believe. So a lot of this information literacy, because there's so much more information out there now. And they were saying we need time to discuss and to be listened to by providers. And again, when we were looking at some of these Black and minority ethnic groups, they found it even hard. They were saying, trying to get access to GPs and be able to talk to them about their concerns was a real problem. So this information literacy, that lack of knowledge and education and the overwhelming sources of misinformation and disinformation, people were really struggling with, and then the lack of localized and personalized messages and advice. So that team said, well, look, what we need to do, we need to clean up our ethnicity data because we've got no idea really who all our populations are, because ethnicity data is so poor, so we can really target where we need to. And then they really started to look at developing and testing a range of creative, personalized and localized health information, education and communication interventions. So, and I'll give you a few examples of those. Creating talking spaces, because parents wanted to be able to talk to people and to have the skills to do that's the critical thinking. Some community outreach events and trying to break down silos where you've got public health doing one thing, primary care networks doing another thing. And then, even when we have public health saying funding our project, then they're going off doing things without talking to the community innovation team. You think, what the hell are you doing? It's like you've said you'd fund us because you want us to get these insights, and then you go off and contract a company in London to go and do some work at the same time, which really didn't, when you had a community innovation team that close to the community. So it's really trying to change that kind of silo working, which is a challenge. So in Central and North Liverpool, some of the resources they've produced some great video assets and a photo exhibition. This is trusted local health professionals answering questions about measles. And these are professionals from the local area. So when people see them, think, oh yeah, I know Dr. So-and-so, or I know this nurse, or I know this care coordinator. And so that was one of the visual aspects. Another thing that they've been working on, which was the use of and this is just starting, is benevolent rumours campaign. And the idea being, well, what's been very successful during COVID were the anti-vax and some misinformation and the rumours that spread there. So this team has actually said, well, let's create some benevolent rumours and produce visuals which look nothing like NHS visuals, and to try and get people to look at these in a different way. And so these are going to be shared via community WhatsApp groups, because these are often those invisible networks which we don't see, where people trust the information in these kind of WhatsApp groups, physical posters and public spaces, and just been very different to NHS comms. And the barcode, I'll show you what it will take you to a video and other sort of bespoke assets rather than your typical NHS assets, which will not work in many communities. This is Anfield and Everton, and so they've been working on a Be Breast Savvy campaign, and as you can see, it's a very lively campaign. We have, we have massive cardboard bras which have a poem, uses humour to try and tackle people's fear about going for breast screening. Have all kinds of, we have sewing going on where people are sewing boob pincushions whilst talking about their fears of why they wouldn't go, or why it's inconvenient to go for breast screening. So all kinds of, just make it far more community facing and less threatening. And again, in their root cause analysis, again, one of the biggest messages came out, well, women was just simply saying, it's not a priority for me. I've got too many other competing priorities. I'm not going to go, and it's not convenient. But north of Liverpool, the closest, there's only one place you can go for breast screening. It's 2 bus rides away. And so you're talking about at least a half a day out of people's time. And often these women may be carers or on 0 hours contracts. So it's really, really difficult for them to go. And if they feel well, then it's like, well, I'm too busy looking after everybody else, or trying to keep my children fed and with a roof over their heads. We did see there were quite big knowledge gaps about the benefits and risks. Most women didn't know that breast cancer is the most common cancer in Liverpool. There were some, some issues of misinformation there. But I think the biggest thing were the fears, the anxieties and embarrassment around what to expect when being screened. And also people were really fearful of waiting for results. And so it was like, well, I'd rather not go because I don't want to know. I'm worried it's going to be a bad result. So again, here, a lot of this work was about, there was actually a breast screening bus was an Aintree at the start of their work. So they did spend a lot of time trying to get people into that because it was more local. Again, they developed and tested a range of creative health education and communication interventions. They took the road, they called it the Be Breast Be Breast Savvy Roadshow. It went right out into community events. We were working very closely with a very trusted community organisation who negotiated to go into like ASDA, into local libraries and other community spaces where people felt comfortable to talk to a friendly team about what their concerns were. And in this one, we used both old and new media because, again, you're talking about women aged 50 to 71. Many of those are not using social media, Facebook and Instagram. So we also did a lot of the old school approach, of flyers and so, as I said, word of mouth by working through a range of community organisations. So that shows you the kind of, this was like the flyer we had, the different locations. We were at Great Homer Street Market, which has a huge footfall, Asda's, sports centres, libraries, Everton, the community shopping centre, so a real range of places. And again, this was very much promoted as come and have a chat with us, very kind of a friendly approach. We also worked with influencers. This was a presenter from Radio City who was great at who has a big following, trying to again look at different ways of amplifying the message. That's an example of the one of the massive cardboard bra, which was sent to all of women who had not attended their breast screening to try and encourage them to come along, using humour. It's a gentle use of humour, but whilst also explaining what to expect. And again, we produced a film there and a photo exhibition, which would travel around with the Be Breast Savvy Roadshow. So again, lots of innovative stuff going on. So I suppose in terms of we're looking at sustainability and there are challenges here. I think Project Titus is one of our favourite sayings, and I would argue this, and I have seen this a lot when I work overseas as well, is you can have successful projects, but it's how do you then turn them into and really embed them. And it does require the primary care networks, Liverpool Public Health, the City Council all working together to say, well, if we're really serious about this, we're going to have to resource it properly, which does mean there needs to be much greater clarity on roles and responsibilities and I think on the leadership and drive for this kind of work. I think, again, in Liverpool, what we're grappling with is how do you sustain this when you're working with volunteers, with community champions, working with creatives, because, this does require funding. And where does that funding come from? I think one of the things we're going to be interested in at our learning event coming up is to find out what the non-funded primary care networks have managed to achieve. So whilst they had the training and were given the model, they were left virtually on their own, just with a Amina would touch base with them sometimes, whereas the other teams had a far more intense support. So I suppose the question now is, we've been working with 4 primary care networks who've been getting the full package. How can we cascade that model in a way which is not so intensive and which really becomes owned by, I would say, probably the local authority? So it's that by trying to get that buy-in, trying to get rid of this silo working, which is really so tedious. Surely we're all working towards the same aim. So why the silo working? I don't understand. And I said in Liverpool, this new neighbourhood model has been very much promoted. There are 13 neighbourhoods. No, there's 13 neighbourhoods and 9 primary care networks. So I'm still trying to work out how those kind of mesh together. We also know with the neighbourhood model that the neighbourhood managers who have been appointed, many of them are not from those communities, and that may be a challenge in terms of making it work. So we're interested to see what happens there. So what we're really saying then is, what can be scaled up, what can be sustained, we need to be able to know how does all this fit with the overarching community health and primary care strategy, which means we do need those leaders within Liverpool to get to, I suppose, agree. What are the funding priorities? Are they really, whilst there's a lot of discussion about the importance of having this integrated approach, how is it going to be funded? What are the organisational commitments? I think one of the things which I think interests me most is, what are the right metrics and what is a true measure of impact? I know that when we speak to Public Health Liverpool, obviously they want to see, has MMR uptake increased? Has breast screening uptake increased? And these take time. Behaviour change takes a long time. And we need to be looking at other measures as well, I think, in terms of actually how, are we really building trust with communities? And over the longer term, how are these are we getting true teamwork, multidisciplinary teamwork? So I think, we've got to go beyond the normal metrics and include some softer metrics there as well to measure that impact, because just looking at sort of improvements and uptake doesn't really tell you very much about why you got that impact. And how can community assets be more involved, getting these creators? Because I think one thing we have found is that involving creatives has been really powerful. And so we're trying to challenge primary care networks to do things differently and to go beyond that normal status quo. And so bringing creatives in and community organisations, it brings in different perspectives. And I think the teams find it very refreshing as well. So I think I've said enough, but what I would like to do is just to share one of the assets that has been developed by one of the community innovation teams, which is a film on MMR, which I just think is very relevant at this point in time. So I'm just going to share that, and then maybe we can at that point then sort of discuss some of these big challenges, I think. So let me play this.
You might not think she's scared of needles because she's got tattoos. But since COVID, it's just been her and the kids and a lot of fake news. And her ex likes conspiracies, but he doesn't like having the kids. And her mum is pretty anxious, and this leaves her with nothing much. No toddler groups, because that's just orcs. No real mum friends, because no one talks. And she doesn't know much about measles or mumps and what the F is rubella. She can't debate the pros and cons of the MMR vaccine, not with her ex-fella. And her nan passed away young. So there were no stories passed down. She doesn't know her nan's brother died from measles. She doesn't know what life was like before safe vaccines came from needles. You might not think she's scared of needles because of the size of the fillers in her lips. She's beautiful, but she's scared. She's scared of jabs, she's scared of vaccines, and she's scared of hurting her kids.
That's not your typical NHS video. And that came out actually from a community-based participatory research workshop in which we had creatives, volunteers, community organisations and members of primary care teams all together. And that poem was literally written in 10 or 15 minutes and then has been updated a bit. Then the primary care network took it on board, added the video to it. And I think it's a great example of a more creative health approach when you involve, your own communities, creators from those communities, and work together with the primary care providers. So anyway, I think that's enough of me speaking. So I'll hand it back to someone else now.
Much about what we do in Kenya and how the differences between Kenya and Liverpool really will improve, I think, the concept of community health in Liverpool. But what I would wish to add really is, for us, strengthening community health systems will, in most cases, improve health equity across all, spheres of, let me say, generation and all, because a community that is healthy transcends to facility having very low cases of advanced diseases, hospitals having very low cases of certain diseases, like, say, in Kenya, we say malaria or unskilled delivery and those many issues that we have. mortality rates and all that. So once we strengthen the community in terms of their health, in terms of their response towards health, then we will have very low cases of advanced diseases in hospitals and referral hospitals too.
Making a couple of notes and just thinking about, you know, what this phase of the Health Equity Liverpool project has been like. And I think some of the interesting things for me are bringing on board the creatives, the local creatives, who alongside, I mean, the PCNs, the primary care networks are very different. Some of them have people who are in situ within those communities, who are trusted within those communities and therefore experts in their communities. But that is not mirrored across the city. I think bringing creatives on board who also have an understanding of the communities that and some of the issues. I mean, they've gone above and beyond in terms of researching about measles uptake and trying to develop their own understanding of some of the barriers and having those conversations with people that they trust, and then taking the steps to develop creative assets, some of the assets that have been shared. But I think one of the biggest things in its entirety has been the collaboration and the value of co-production and the commitment of everybody coming together saying, okay, this is an issue that's based within the communities that we're from or that we live within close proximity to or we work in. How do we come together with our own understanding, our own knowledge and our own expertise to address this issue with a view of ensuring that the community have a voice in shaping what the approach is and the outputs are. And I think the teams have really committed and invested in doing that. And when you look at the gap between these teams, the community innovation teams and the public health team, who are looking at this from a distance, from a position of distance, and through gathering the insights and their understanding through different partners, these individuals are actually there on the ground, they're trusted, and they have access to conversations and relationships that a lot of other health systems partners don't. So I think similar to Kenya, there needs to be a bit of a shift and an understanding that in order to address health inequalities, particularly in Liverpool, there needs to be a shift in terms of resource, commitment to sustainability, and an acknowledgement that actually the expertise comes from somewhere else. And it's only through a true commitment to partnership and collaboration that you can truly address the inequalities that exist here. So creatives that I've worked with in this phase have been poets, individuals who are, you know, cartoonists, graphic artists, who have delivered messages in a totally different way and view things through a different lens. So I think it's been bringing those different modes of communication together and recognizing that the traditional approaches haven't necessarily worked. That also, right the way along, the teams have consulted with people. So when they've developed resources and assets, they've gone out and had conversations with communities because they've got that direct access to people to say, what do you think of this? How would you respond to this? Would you engage with this? Do you think this would speak to people that you know who maybe are vaccine hesitant or maybe don't want to go along to a mammography appointment? And through those conversations, they've been able to shape what a different approach and a really innovative, and I don't say this lightly, kind of approach to communicating with people is. And it's at that level that people want to engage with, and actually it provokes discussion. So
what I loved about this conversation was the cross-fertilization between Kenya and Liverpool, and the occasions in which Liverpool learned from Kenya.
Absolutely.
And my question is about the role of elders, indigenous healers, if they exist, integrative and complementary medicine providers, and spiritual people, because they have been in the Western systems divorced to a degree. And I will say one last thing, and I'm walking towards my oak tree. I do a lot of work with trees and their role in health. So when we talk about community, to Paul's question, what's a community? Let us not forget that our health is so intimately related to all the other living creatures that we are fortunate enough to dwell with.
Certainly in Kenya, the way the community health system is structured there is they have community dialogue days and community action days, and that is often through working with the local chiefs. And in fact, in the community innovation teams, we have local chiefs on those teams, and they obviously they are those elders. They are listened to, and so you have to get those people on board, in the approach, because that often will be the way through which you're going to work and get access into those communities. But Mandela, maybe you just want to talk a little bit more about those kind of traditional structures, which I think are much stronger still in Kenya than they are here in the UK now.
Yes, thank you, Vicky. And you're quite right about the fact that we have elders, we have chiefs that are really utilized to pass messages in the community that affects the health outcome. We also work with a more integrated approach when it comes to community work, especially working with the WITs in Kenya. So the integrated approach here means we involve the influential people at the community level and say in a unit. So you'll have village elders, you'll have chiefs, you'll have probably religious leaders, and they all have different roles, and they are all, our main aim here is to choose a particular influential individual that is keen, and it's very keen to try and change the narrative of health equity in terms of provision of services and all that. Some of them might be there for the returns, but if you get the right person who will actually change the narrative, who will talk to the people, then it has a bigger impact compared to someone who is the other silo. So the difference with what we work with in Kenya is our polarization is along ethnic lines. So let me try to explain this. So when we select influential people, you select influential people based on some of the challenges that you want to tackle. I'll give an example. If you're in a setup where religious affiliation might hinder, say, access and availability of health services, then you might want to incorporate a religious leader and train this particular person and capacity build this particular person so that he will educate his flock, he will educate the people that go to church about the importance of doing 1, 2, 3. If you're in a setup where it's a cultural hindrance towards health equity, then now you'll bring again now an elder who sits maybe in a chief baraza or sits in somewhere that is, they can discuss these particular issues. Then you bring them on board, and then you train them, you encourage them to use proper means to tackle health issues. So another example would be if you're in a place where, say, we still have a lot of unskilled deliveries, you bring on board those we call traditional birth attendants into the WIT. So they're also able to be taught so that when mothers go to them for services, then they refer these mothers to the health facilities. So before I stop there, I wanted to just reiterate on what Amina said about creatives. And I want to put it in this aspect. If you watch television, there's always adverts about a product. So where creatives have a major impact is in this sense. When you give somebody information plainly like, okay, you need to go to the hospital, that is not really attractive. If you watch what the media is doing, they kind of try make it a dramatized way of advertisement, or they look for an influential person to come and sing a vibe in terms of that particular product. So even in community work, in terms of passing key messages to the people, I think creatives is the norm now because we are in a digital space and everybody wants to be affiliated with something that is trending or something that is interesting. And one thing that we forget is our kids actually have more information nowadays than we have. And then they have access to so many other creative ways of reaching this information. So by default, when a kid will be interested in what is being talked about through creatives, then the parent, again, by default, will follow it and will be like, okay, well, this might work. So that was to support Amina's. Back to you.
Or I think you said that there was reluctance on the part of primary care professionals to collect and use the data that they have all around them.
Yeah.
Is that right? Does that more or less correlate?
Not so much a reluctance, but just not really using it or drilling down into it and looking at what it was telling them. And I think I think what the powerful thing was combining that routine health data then with the insight data. It really gave them sort of, I suppose, a new energy of what they needed to tackle. I just think certainly, from the work we've been doing with the PCNs and the primary care teams, is just that seem very overwhelmed at the moment. And I think, we've been trying to give them sort of, I suppose, again, I talk about the structure, system support and tools to help them do that and break it down in a way that seems doable. As I said, we've seen huge problems with data quality. And so, one of the big questions is, can you even trust the data that you've got? And often this is about poor coding or just, just not actually having the time or the headspace to actually even look at that data. It gets put into the system, but then doesn't get used. Every GP, my understanding is that certainly in Liverpool is that if a child hasn't had their MMR or if a woman is overdue her mammogram, and the alert comes up on the screen, but then when we talk to the GPs, they say, well, I only take one issue at a time and I haven't got time to do that. So I don't, so even when the health information system is there advising them to talk to their patients about certain things, it still doesn't happen. And I think what we're trying to really do is empower those teams to use their own data. And I think the more they use their own data, then the better quality that data will become. Because if you're using the data, you want to have better data.
Are you saying that it's a matter of power? If you empower somebody, it usually means there's a problem of power in the system.
Well, I just think, so much data gets collected, but very little of it gets used at the local level. And that's what we're really trying to encourage is to, empower those teams to use that data at that local level so that they themselves can plan as a primary care network or as a GP practice, how they can better engage with those disengaged communities who they are meant to be serving. And I just don't think, certainly with some of the PCNs, that there's very little engagement with communities going on at all. And I think by getting them to really look at their data, and sort of, I suppose having this framework where it's about data informed, using the data to inform the interventions they do, it's, I suppose, we're trying to get them to love and embrace their data, basically. Because I just don't think enough that's going on. And exactly the same things happen in Kenya as well, where people are just collecting the data because they've got to, or, but actually not actually then looking at what it's telling them. I know maybe that seems oversimplistic, but I think that's certainly what we've found both in Kenya and the UK.
Steve, what's your view on this?
Sorry, is that for me?
Yeah.
Well, I think the word power does have some resonance here, that I can quite understand why I would not do a task that I've not actually agreed to in the first place. I just wonder if you're encountering the widespread, almost alienation of the labour force in the NHS and in social care. people who are poorer in terms of their ability to influence the world they live and work in than they've ever been before.
I think you said in your talk, Vicky, that the public health neighbourhoods in Liverpool and the general practice primary care networks in Liverpool have chosen not to share the same boundaries.
Yeah, well, there's different boundaries. And in all honesty, the primary care networks, I know, Paul, you always talk about a primary care network serves a population of about 50,000. Well, so in Liverpool, you've got primary care networks with 4 GP practices and others with like 18, and some which are meant to be South Liverpool, but stretch for, huge, they've got huge geographical footprints. And so I do struggle with the neighbourhood model and the fact that primary care networks, there's very little overlap, and I know for Liverpool City Council going forward, they see very much this neighbourhood model as the way forward and having a far more community integrated approach. But then if the PCNs don't match with that, does that, I'm not, well, we're going to find out from them on Thursday at the learning event, because we've got the head of the neighbourhood model going to be talking to us, because I want to understand how it's all going to work together. And that's the neighbourhood model obviously is much broader. It's not just health, it's everything.
I could well imagine that large numbers of people have never actually seen the power of data to do anything at all. If it's not valued, not speaking to what they want to do, they've not agreed to it, and it's sharing different boundaries. I mean, I can imagine data being rather irrelevant to people. Anyway, Linda.
Yeah, thanks very much. Wonderful. Thanks very much. I really enjoyed that, Vicky. It was brilliant. And also the input from Amina and Mandela. Very interesting to look cross-culturally as well. I'll just feed a bit of my experience, which was working in New York, particularly in Queens. And I worked with, it was a hospital-based arrangement, but we worked very much with infectious diseases. Therefore, we reached out a lot, and we worked with non-governmental organisations across the borough of Queens. And I wanted to do some research working with local NGOs and find out the experience of women affected and infected with HIV. So the approach we used there was very much I was the researcher, and they were the data collectors, but we trained them. So we had nothing like the size you're talking about, or certainly in Kenya, Mandela's population sizes. But it did work, because obviously I was able to get the data from them, but I also trained them on collecting the data, which had to be anonymized, because that was super important to the patients, and they told us that. So we worked with the patients to work out the methodology, etc. So I'm just suggesting that because I know the problem is that the PCNs and people working within the system are all exhausted.
They're absolutely exhausted. Absolutely exhausted, yeah.
So somebody taking that responsibility a little bit for them, but feeding back to them was so important. So they learned through what we were finding, and therefore they were gaining from it as well. It was very much trying to outreach the findings as well as taking in the data. And we did find, of course, there was variability in the data, but generally speaking, it wasn't bad. And we had to allow for certain kind of issues like that, but it did seem to do the job. The other thing I did a bit of work on was looking at DNAs, did not attend at a coloscopy clinic, which was obviously really important for the women. And why weren't they attending? And just to reinforce what you found was they were sick. They had court cases. They had kids. They were looking after other people. They put them first. Those were the reasons. They weren't being, they were being driven by those sorts of issues. So it is a big cause for concern. And then the other sort of thing I was really just thinking about, how you could sort of develop the data, because I agree with what you've said about some of the data being kind of longer term, but, the audience needs that kind of data to influence it. So I was just wondering about whether you could look at, and it is a question, comparative data between those areas where you've impacted successfully and those where nothing has happened or little has happened. I just wonder about that.
Yeah, well, in this new funding we've just got, which is going to be, we're going to be working with up to 15 primary care networks. And this is going to be very much, again, using this creative health lens. I think we just started experimenting already during this project, so that we could hit the ground running with the new project. And there, what we're doing is we're working with the University of Liverpool, who they have access to the database across Cheshire and Merseyside, so they can access all the GP data. And so that's exactly what we're going to do, is they're going to looking at the hard data through the databases, and we won't be working with and we'll work with a certain number of PCNs and GP practices, and then they will compare the difference between those who are involved and those not. Because one of the things which came out when we're looking at this creative health approach is we were saying to commissioners, why are you not commissioning creatives? And they'll commission these tiny pathetic little projects for like, oh, here's a little bit of money for 3 months, all lovely project, but then they won't actually commission creators to do bigger things. And he said we need the evidence, and so this is why in this next phase we're going to be working with University of Liverpool, who's going to be doing the hard data crunching, and then looking at and then comparing that with some of the softer metrics, and then seeing, is there a difference, how much of an impact? Because if we can produce the evidence to commissioners, we want to shift the way they commission towards we want Liverpool to have a creative health strategy. That's what we're trying to convince Matt Ashton about. But Manchester already has one, so I said if they've got one, then Liverpool definitely needs to.
They've got Andy Gordon, that helps. But yeah, no, that's great. I mean, the other thing I would just advocate very strongly for with the university involvement is really getting, as you are, community involvement, because getting the questions in the right way for the different communities would be so important. And finding out from the community what's acceptable to them and what's not acceptable. That's what I personally found was really important.
And I think this is where Amina was saying, it's that collaboration, that that's the co-analysis of data, and the co-production of interventions is really important. In this new phase of funding, we've got a whole community-based participatory research is underpinning it. So we will have we'll have people from the GP practices who want to get involved in it. We're going to have volunteers, we're going to have artists. They're all going to get the community-based participatory research training, and so that they will together be doing a lot of the research and asking the questions, developing stories, and so it's brilliant. Quite exciting.
It is exciting.
We don't know how we're going to handle it yet, though, do we, Amina, with all these extra PCNs on board?
It sounds amazing, and really all credit to you. I mean, the only other thing I would say that really worked for me was not only getting the communities involved in the design of the research, but also the interpretation.
Exactly.
And actually, they spotted things that from a medical perspective make sense, but it made sense to the community. So that really was important as well.
Yeah.
I know there are other people on the call who've got experience of data generation and use by groups of practices. So it'd be good to hear a bit more of that before this meeting's ended. I know that in Ealing we had clusters gathering data, routinely gathered data, and had a little competition going on who could through complex interventions, doing lots of different things, achieve changes in the data more than other places. But let's come back to that. Craig.
I found that an astonishing performance. Really amazing. I feel like the headlights on my car is spattered with so many ideas. I'm overwhelmed by it. But one of the aspects, there's two things. The first is the concept that you can't measure something without changing it. I wonder what effect on the community sense or cohesiveness had your teams had. I mean, maybe I could imagine situations where all the chat within the community, everybody's talking about it every other day about, oh yes, we had the CIT team, I was talking with them, and it becomes the whole focus of that and has an impact of bringing people together. Was that what you found, or have I got the wrong end of the stick?
Amina, I'm going to let you say a little bit about that.
I think one of the things that we found was that
people were actually willing to engage in a conversation and speak to people about their kind of obstacles, their barriers, and then go again for a follow-up conversation, acting as a small nudge towards the direction of maybe engaging with mammogram appointments, or, you know, going to booking their child in for an MMR appointment or cervical screening. And I think there's two examples that spring to mind. One I'll let Vicki tell, and I'll pass that on. But one I'll tell myself. There was a conversation, and it goes back to the question that was raised earlier about faith leaders, but here in the UK. So I think the team have kind of gone out to so many, you know, different kind of places to have conversations with people, and have realized that they need to go where people are going already. Times have changed. You know, saying to people, come along to a health event, doesn't actually achieve what it used to achieve, because we're all so pressed with all of these different conflicting priorities. So they realized we're going to have to go where people are going already to have those conversations. So I think there was a family fun day in a faith institute, outside a faith institution, and there was a conversation with a parent who felt that actually I can't immunize my child because my child's SEND. So what do I have to do? And it's only through having that first conversation with someone who they trust, which led to another conversation with a clinical staff member within a primary care network, that actually put her at ease and made her feel more confident and feel trust, which enabled her to go along to a second appointment and book in to immunize her child. And I think what's starting to happen, and it's only at the very beginning stages, I'll say, with the measles team, is they're starting to have these multi-layered conversations within the community that are starting to have a ripple effect. And I think it will lead to what you're talking about, you know, creating that buzz. Actually, if you want to find out a little bit more, go and talk to the community innovation team that are in situ within your local area, because you're likely to be able to find out the information there. And, you know, we feel comfortable talking to them and confident. So, yeah, I'm going to let you tell the story of Lisa from Whisk.
Yeah, I think, this was another great example. With our Be Breast Savvy Roadshow, it wasn't just we had our core team, but then we also were working with, we had Northwest Cancer Research, we had Whisk, and they're the Women's Health Information Support Centre, and they do a lot of health and wellbeing support to women who have had a very tough time in life. And Lisa, she's a fabulous woman who came to all our roadshow events, and she's sort of trying to increase talking about breast awareness, a self-examination of breast, the importance of going for screening. And she finally admitted, after we'd done 6 roadshows, that she actually was one of the women who hadn't been screening herself. And it was only after all of that and being with the team that she said to me, she said, I have to admit, finally I went and everything was okay. But it sort of sums up, though, just this thing about it takes time, and you need those multiple conversations, just so, which is why we've been trying lots of different interventions, and it's like giving those messages in lots of different formats, because even we all know this behavior change takes time, and it's how you get those messages across and who gives those messages. And and I think that's what the community innovation teams spend a lot of time thinking about, is and as I said, it's not getting away from that hard to reach, but really think about how can we take ourselves to the places where the communities are and speak to them in the language that they understand. Don't judge them, don't blame them, because I'll just have to give one other story with the breast screening unit who told me what an excellent service they had. And I said, yeah, I'm sure it's very excellent. But the problem is less than half the population are using it. So it may be clinically and radiologically very excellent, but you're not reaching all these women. And we were trying, we were shared with them the mammogram poem that had been written. And that they weren't too impressed about us trying to use humour. But anyway, we went ahead anyway because we tested it in the community, and the community said we're not. Actually, this was really helpful. It gave me so much information, and I didn't feel it was trivializing anything. In fact, it made me more confident now. So, again, it's just that thing about being, using the right language and in a way that communities can receive that language, I think, as well.
Can I ask one last question, Paula, very, very quickly? I asked you what was the impact of the CIT teams on community cohesion and what went on within communities. What impact are you going to have or have had on the conventional NHS, these primary care teams? And how are they looking at you now? This kind of goes back to what Steve was talking about, and you were also referred to, the GPs and so on have to engage and use the data, but they've got to want to do so. And I didn't get the impression that they do want to, and so on. So I'm intrigued to I'd love to look at behind you and see what impact you're having on those people.
Now we've only got 2 minutes left.
So I'll go away. Goodbye. Sorry.
Go on,
I'm going to give a quick whistle stop example. So for us, the GPs, oddly enough, that we're working with have been really engaged, and they've trusted the different people who are experts in the community to kind of shape the way forward alongside them in collaboration. But one thing we found is the team, through the behavioural insight, found out that people were worried about what the vaccine was made of, the contents, the ingredients, in terms of, whether it was halal or not halal, or suitable for vegetarians or not. So the community said, right, we're going to develop a message that speaks to this. And they said that, it isn't there is an alternative available. And after developing this message that they received some kind of criticism for, their message is now being used by the public health team. So originally, they didn't want to use similar messaging. They wanted to use a different message, but they've adopted the messaging that's been actually developed by the community innovation team and are putting that information out to communities across the city and across the region. So sorry, I did want to say that actually the team are shaping public health messaging, both locally and nationally across our teams. So I'll stop there.
And they may actually be shaping not just the messages, but the whole way of thinking about.
That's what we hope.
Does it? I mean, I'm rather struck by 2,500 community health workers adopting their priorities, and 8 community health workers that are doing what they're told by the professions. And you've just changing that. Nobody's hardly noticing, are they? This is how. Right, we've got only
maybe connected with Craig's point. Amazing in a way. I think there's an amazing amount of kind of structure things in that discussion. Structures, formal ones, informal ones, and obviously a CIT team isn't a formal structure or legal body, but it made me think about really how poor the current formal structures are doing. Maybe I mean we didn't mention health and wellbeing boards once. We've got the new integrated care partnerships, and these sorts of bodies, presumably within the legislative framework, are supposed to be picking up some of this stuff. And it almost kind of feels to me that the people on those boards are sort of not doing their homework in a way.
They don't know.
I think they talk about it, but they don't know how to do it.
One, Vicki, I love your energy. That's the main thing. That's because that goes a million miles, and also the rest of your team. So that's brilliant.
I know. Thank you, team, for coming along. We've had a very long day and few weeks. So, great.
The reason I haven't said much today is because there's so many thoughts whirling around my head that it's difficult to break them down. Maybe we almost need a reflection and follow-up of some of these ideas. But one is that when you set up these bodies, when we developed the primary care networks as the experimental primary care homes, it was full of energy because it was a bottom-up thing. As soon as it became government policy, well, that was a dead hand. And then you get stuck with people who just, whichever organisation they run it in the same way. And so it just perpetuates. And one of the interesting issues, since primary care networks aren't statutory bodies or legal entities, as distinct from the rest, they have no official status in that way, is both its weakness in the traditional sense, but its strength, because then, instead of it being a hierarchical model, each individual practice or clinician should be able to influence and energize, and so they could have a different leadership, but not the same leadership all the time on different events, and to create that much more organic leadership model. And that's going to take time. That's what, so the practice may well be the leader of the CPN rather than the CPN being the be-all end-all, or one clinician or one non-clinician. And until we begin to reshape what our management culture is, but what happens is you set up this structure and we all just shrug our shoulders and accept the same old, same old. And also we've got to look at things like incentives. I mean, I don't just mean cash, but incentives work. The reason that when we did all our work in our practice was because we had a budget. A budget is empowering. It also makes you more accountable. But the health service hates mid-devolved budgets. It's all, I mean, it's so complex, it's so frustrating. But those are just some random thoughts. But the PCN, in a way, we're almost expecting too much of it. But then we have an opportunity to have this, diverse leadership, which is exciting. And people like Vicki, you see, if I was still, wasn't 900 years old, and Vicki could be one of the leaders, even if she had nothing to do with the damn organisation. It's about scope. And the health service is determined to negate all that. Yeah. And that's a big issue for all of us.
Yeah.
I thought it was pretty great, Mandela, talking about training the village leaders. I mean, wouldn't it be rather good if we could train our leaders in primary care networks and general practice and whatever? Because these things are known. We do know how to have leadership of sense making and how to collaborate. We know how to do that. And we're out of time. Sorry, David, go on.
It's whether they want that. See, it's all right to know what to do, but you've got to have somebody who wants to do it in the first place to get the show on the road. One of the things I found is picking out likely people in organizations. Don't always go to the traditional leader, formal leader, and try and find the people who want to do. And that way you can get a network of energy. This all, I mean, I'm sure that's what Wiki is doing and all your star people, but this takes time and energy. But there's always people around in organizations who want to do that bit more or have a different focus. And so that's where you need to, but who is going to organize that? Everyone says, oh, I'm too busy, which of course they are. So there's a certain deadness. And one of the problems when you have a new organization like a PCN, statutory or not, is there's a chance of an icebreaker, but the ice quickly sets. And therefore you have to seize opportunities, and so few people do.
Okay, what is it about the general practice context that helps people to become quite innovative when they want to be? And there's something to do with seeing such a diversity of issues and so many things that are beyond the capacity of one individual to deal with. So